Welcome, everybody, and thank you for attending today's presentation titled When Consequences Are Vague or Long in the Future. So again, just to introduce myself, I'm Dean McKay with Fordham University, where I've been for a long time, and I'm also now a member of the Board of Advisors for Better Living Center for Behavioral Health. I want to start by thanking Better Living for making these trainings possible. As I've come to call these, this is the training tour, if you will. And so this is the fourth in the series that we have planned through till mid-May. There'll be future trainings after that, I'm sure. For now, these are the ones that we've scheduled. I'll mention at the end the ones that are upcoming. Just a little note before we get really started here. And I'm grateful to getting the opportunity to work with Better Living. As I've mentioned before in prior trainings, if you're watching these recordings, I've had the chance to work with them for the last several months and gotten a chance to take a look at some of their outcome data. It's been very nice to see the good work that they're doing for people with anxiety, OCD, and trauma. And I'm looking forward to doing more work with them in the future in disseminating some of those outcomes related to their behavioral training model. And as part of this series, the trainings that have been put together are in keeping with some contemporary issues that clinicians regularly face that either the available literature is not particularly detailed about, or where it's relatively silent, frankly, and the opportunity is here to really talk about some principles of behavior and how they may have been adapted in everyday clinical work. And so today's topic is one that anybody who's worked with people with anxiety disorders and OCD may be familiar with, but it nonetheless is consistently a pretty serious challenge that needs to be dealt with. And so with that, go to the next slide. Whoops. There. All right, so let me give you a little overview of what our plan is for today. So first, our opener will be to just provide a little bit of a review and also some of the basic science that is out there that connects feared and avoided situations and stimuli and the anticipated feared outcomes. We'll discuss a little bit of some intervening cognitive variables. What this will include will be some clinical strategies that can be adopted in addressing this when clients present with fears that are related to situations where the time lag between that exposure and the feared outcome is great. We know that this poses a pretty difficult clinical challenge because it's sometimes harder to procure a return to baseline emotional experiences during sessions when you do exposure for something that's long off in the distance. We'll go through some clinical presentations for which this is fairly typical. We'll discuss what I think is a reasonable contextual model for how you might go about doing this. And then we'll put all the pieces together with an illustrative case for our purposes. And then at the end, there will be time, as has been true for each of these, for some question and answer. Okay, so my apologies. Even though we've done this a few times, my ability to work the material, there we go. All right. Not great with the technology even at this point. So the standard model, the way that we think about exposure and the way that many of us may have been trained to think about the model of treatment for anxiety is that someone presents for therapy, they report that there's a whole bunch of feared situations and specific stimuli that they may be avoiding, and then they tell you what the anticipated outcome might be. That anticipated outcome, that's a prediction that they're making, and the intervening variable that has been somewhat underemphasized in a lot of the basic literature and in the training materials that you may have had as you got into this area is time. So this is an issue that we need to deal with because as clinicians, we directly inquire about the condition response and we're at the mercy of the self-report that the client has. In other words, the client formulates predictions about what they think will happen. and then they are guided in their behavior based on that. Now, how they got that to that point with a conditioned stimulus being the target that leads to their apprehension, well, that's less clear. We don't have a real clear way to understand that. We do know that there's a body of classic research literature that talks about the degree that someone is familiar with a conditioned stimulus and the degree that it elicits a conditioned response. And so we know that as you avoid more, then it also creates greater degrees of anxiety because it is an isolated stimulus. But the intervening variable that's been less well appreciated is what is the person saying might happen as a result of this. Now, by the way, this concept is true in all of our lives. So it is not unique to people with anxiety disorders. It is actually something that we all are familiar with. If you're not sure of whether or not this is true, let me give you an example. So if you are attending this and you're a smoker, and you've heard again and again in your life that smoking is bad for you, right? That's not a secret. But the time lag between the actual act of smoking and the accumulation of the outcome is long. And so for each cigarette smoked, the consequences of that cigarette being smoked is actually trivial. It's through the aggregation of that that we have a more serious anticipated outcome. Now, people with anxiety disorders operate through a different frame of reference. So they will take the position, if I do X, then something, outcome Y, that I don't want to happen might occur. And because the risk in the view of that sufferer is so great, then they would rather not take that risk. And now, in many instances, because the anticipated outcome feels like it will be serious, but also because it seems a little intangible, it's sometimes vague. They may not be really clear about it. If we use my smoking example from earlier, and again, if you're a smoker or you know someone who is, think about the effort to try and persuade someone about the deleterious outcomes. We don't really know what they will be. We know that there is something that might happen, don't really know what. And so we're really kind of operating from that frame of reference, but with it turned upside down a bit because the anxious individual is saying, I can't do X because of vague outcome Y someday, or because of specific outcome Y someday. And that creates a challenge for us because our task in therapy, what we've been told all along, is you got to do exposure. You got to do exposure because that's the thing that's going to help. But we have to overcome this problem. By the way, how important is exposure? If you're unsure about this, there was an article that came out just about a week and a half ago in Clinical Psychological Science from Michelle Krask's research group, where they took naturalistic outcomes for over 600 clients and over 8,000 exposure exercises. And the data show persuasively that exposure produces better outcome. Now, not baked into that, however, is this issue of the time lag. And so that's what we're going to grapple with. So let's talk about this other element, and that's the intervening cognitive variables. So that we have to kind of navigate this with the intervening cognitive variables, even if at the end of the day, you still want to have the client engage in exposure. So we know that one of them that doesn't really fit cleanly into any specific kind of cognitive dimension that you may have read about or heard about, like some of the other ones listed here on my short little bullet list. But there's like a general prediction. We as clinicians may try to reframe for the client what they say into some other kind of cognitive dimension that we're familiar with, like black and white thinking or catastrophizing. But ultimately, the client has an inner verbal language that they rely on, and that comes up spontaneously as they go through the day, and they either avoid or, when they encounter, do things to mitigate the consequences of the situation that they have encountered. So we should really think about the predictions made by the client, the words that they say that they anticipate are going to be the result of encountering some feared stimuli. that those words are actually their inner language. We should work with that inner language, even if our clinical instinct is to say, I'm going to cast this in a particular framework. So that balance is something that's worthwhile to put into play, and also to recognize that things that people may say may not really fit neatly into any of the categories that we arrive at the clinical situation with. So that's why I start with general prediction. We do know that many people will say things that sound very much like intolerance of uncertainty. Uh, as a research matter goes, intolerance of uncertainty has shown to account for a very, very large amount of variability in the kind of avoidance that people with anxiety problems struggle with. So you could certainly start with that, and you'll be on good footing when it comes to using that as a cognitive intervening variable between the feared stimuli and the anticipated outcome. So that's a very good one. Another popular one, of course, is overestimation of threat. How often have we heard people say things that suggest that their appraisal of how dangerous something may be is far greater than the actual danger it poses? So that's a fairly common concern. And so the lag between the exposure to the circumstance and the feared outcome oftentimes is based on an elaboration of threat that is much, much greater than it may actually pose. Um, I know on some of these prior trainings, we've had people from abroad who attend. So I'll use an example that is a kind of uniquely American one, and I'm going to also say it's a little bit of a sad and uniquely American one. But a client who I was working with had talked about her concern that if she thought about things in certain multiples of three, by the way, multiples of numbers is going to come up later in my clinical example, but I'm going to do a little clinical pause here for a moment to talk about overestimation of threat. She used to talk about how if she thought about or did things in multiples of three, it increased the odds dramatically increased the odds, like up to 70 or 80% risk that she would be shot. Now, again, that's kind of a uniquely American example, given that the base rate risk for most Americans of getting shot is kind of high, but it's not 70 or 80%. And so we use that as an example of an overestimation of threat that she harbored when trying to think about how to do exposure. So anyway, so we'll come back to that in a moment, or later on in our morning together. Another issue that may lead to challenges in how we think about this prediction is magical ideation. So people form magical associations between two different stimuli. Again, not unusual. The example that I just gave, multiples of three and its connection to risk, that overestimation of threat that I gave as an example, had a particular blend with magical ideation. Not unusual. Many of us harbor associations in our everyday lives, irrespective of the presence of anxiety concerns, that may be magically connected between things. So this issue is one that it's worth understanding as we leverage the cognitive intervening variable when it comes to doing exposure. And then the last one, inevitably, in a discussion about the lag between exposure and feared outcome, is religious and spiritual ideation. In the context of OCD in particular, if you specialize in treating OCD, you will inevitably, and probably early on in your career, encounter someone for whom the concern that they have around exposure will not have its consequences realized until after death, in the afterlife. And so we have to reckon with that. And even though it's a little bit beyond the scope of our discussion here, I will introduce that as part of the clinical example, where as a clinician, we need to be comfortable talking about religious experiences and how to really utilize that effectively in understanding how to help someone engage in exposure and ultimately live better lives. Okay, so some common clinical presentations where there's a long consequence lag. These are things that are worth looking out for. When someone says to you, I have symptom X. A question that should be in your mind is how long between exposure to stimulus, whatever, and the outcome will this person be expecting? Because that's going to be critically important as part of your exposure work with them. Uh, Contamination fear very commonly has a long lag between exposure and outcome. It's an underappreciated element. And I guess for me personally, in my clinical career, I came to appreciate this early on. So I'll give you a historical note, one that's not as prominent any longer, but at the time when I started as a trainee, and then early in my career in the 90s, a fairly common contamination fear that people presented with was a fear of contracting HIV or AIDS. Now, you're probably not aware of this because in our contemporary times, it's not discussed quite as frequently what the lag is in real terms between infection and the manifestation of symptoms. But at the time in the 90s, the research was fairly early in the going on HIV and AIDS, and it was kind of understood that it took 6 months or more before you might experience any symptoms. And so that created an important challenge as you might try to work on helping someone overcome a fear that involved avoidance of a whole bunch of things that had nothing at all to do with the risk of contracting HIV. But nevertheless, you had to reckon with the risk that the person said that they were facing. More contemporarily, and actually a problem that I guess is not going away in terms of our understanding of it and the mitigation of it. Because remember, at the time in the 90s, when I was starting out, if you were diagnosed with HIV or AIDS, it was effectively a death sentence. We do know now, contemporarily, that contracting HIV and AIDS is associated with a lot of effective medications, and there are many, many people who are living happy and productive lives, and actually are also undetectable, as we know from ads for medication. But there are other conditions where that is not necessarily true. For example, a not uncommon contamination fear that people present with now would be fear of contracting hepatitis. So, hepatitis, uh, the condition can be transmitted relatively easily among people who have it as an infection. And the lag between contracting it and developing symptoms is also rather long. And so, not an unusual one. Obsessions about harm. So you do hear about people who have concerns where they may have said or done something that would be viewed as harmful, and that the lag between when it happened and the outcome is long. A contemporary one, for example, that I've seen in our practice has been one where a person is concerned that something that they may do publicly, uh, they may have a job, for example, where they interact with others and there's a public record of their interactions. They sometimes get concerned that what they do now may, even though it is considered neutral and even socially appropriate, may be deemed at a later date as socially unacceptable. And so there is a hyper concern among some individuals, even though they do not wish to offend anybody, they have no ill intent, but they nonetheless get concerned that what they are doing now and saying now publicly may be construed in a future light in a negative way. Other obsessions about harm that people sometimes can get concerned about the long lag in terms of its outcome, maybe also saying something to an individual on a one-on-one basis where they realize that it had, say, let's say, a sarcastic tilt. I'll use myself as an example. I'm good friends with a colleague in the OCD community. I won't name him because um, he is unwittingly he would unwittingly be part of this, and I didn't clear it with him beforehand. But he and I, when we speak to each other, regularly riff on each other's hair loss. Now, if I were instead the client that I mentioned as an illustration before, if I were instead him, so I might engage in this banter and then afterwards go, did I actually hurt his feelings? this other person, and will that harm him in ways that I cannot easily understand? So, with that as a frame, that can lead to some additional obsessions about harm, but there's a long lag. I don't know how long it's going to take, if it's going to happen, right? So that it's vague, unclear, and the duration is not easily assessed. Religious and spiritual obsessions, as I mentioned before, people sometimes have concerns about thinking or acting in ways that would be deemed blasphemous, and those consequences would not be realized until after death. Health anxiety is a fairly common presentation where the outcomes after exposure are very long and off in the distance. Again, fairly common kind of problem. People present for treatment with all kinds of health anxiety, and and how long it will take for that health consequence to happen is very unclear. And as I mentioned before, the contamination fear and obsessions about harm, uh, those can also sometimes manifest through some versions of social anxiety. So there's a range of clinical conditions. This is not intended to be exhaustive. Uh, what I want from this particular component is to raise awareness about something that is an underappreciated component in treatment. Okay, so let's say you face this, right? Which again, if you're treating anxiety disorders and OCD, you're going to face it. It's going to happen. Um, I'm going to enumerate what I think are a few possibilities for how you might deal with this. This is, again, it's not exhaustive, but just sort of like an opening guide for suggestion. So, one that we don't do as much is create a hierarchy based on anticipated time to consequences. So, let's say as you think about the different things that someone might avoid as you break down that CS complex, the other element that you might include with it will be, how long do you think it'll be before you feel something due to this? So that suddenly changes it rather drastically, because it's possible that someone may be avoiding things where they say, oh, if I do that, I'm going to feel that outcome immediately. And you might say, well, maybe that's a better thing to start with, because we know and we can observe that consequence right away. It may sound on the surface like it's more anxiety provoking, but maybe in the long run, it's actually less so. Let me make that concrete for a second, again, through a clinical example. And these little clinical anecdotes that I'm peppering you with are not part of the fuller clinical illustration that we'll have shortly. So here's the example. I mentioned this guy in a prior presentation, by the way. So if you've been following these trainings, you'll recognize this person. This is someone who I described previously, where in the office that I was meeting with him, we would go to the lab that was down the hall after hours because he had concerns about contracting a medical illness. And we stood in front of the lab with our shoes and socks off. So we stood barefoot in front of the lab on the assumption that people who went to the lab weren't well. And as people who weren't well, there was a higher concentration of whatever illnesses might be there. And bare feet, well, bare feet are a little bit more risky. By the way, I assembled this for him a little bit, and I used some kind of yucky illustrations, one of them based on the concept that in other parts of the world, there are some worms that are human infection parasites that get into us through our feet. And so we use that as a basis for engaging in this. But the way that we started out on this was based on time. As we stood there, what I said was, people come to this lab who have such serious illnesses that their time here is not very long. And because of that, you will probably feel sick from this pretty quickly if we're going to contract anything. So we talked about this through the lens of extremely high risk, but extremely short consequences. So that's a contrast to how we're accustomed to hearing about this. It's also a contrast to an expectation. Remember, most clients are avoiding things because of a long lag that they say, I'm going to stay away from this because I don't want to get this in the future someday. Now, we turn that on its head with the prediction by shortening the lag. So that creates some challenges that we can overcome with our clients by tinkering with the dimension of time. We can also talk about the hierarchy based on severity of consequences. So that's one that also not as typically done. So if you think about the standard hierarchy development is what are the things you avoid, and let's think about how anxious you would be for X. How anxious would you be for X point one, X point two, right? As you climb that hierarchy, but an implicit element of that is severity of the consequences. So if we made that concrete, so let's say coming back to my guy with the lab, we could start out with something like, standing here, we're probably going to contract some illness that it'll be so serious that it will lead to illness almost immediately. And I think at the time, even though it was pre the Ebola scare that happened in this country about a decade ago, it was a known illness. And so I described it to him. By the way, as a clinician doing this, it's good to have at your fingertips a whole list of kind of scary illnesses and other horrible outcomes that you can summon to memory and immediately to dispense as illustrative things that might happen. I'm foreshadowing a little bit the last training that we have lined up for my work with Better Living on developing imagery. And so the burden on you as a clinician is to be aware of a whole bunch of horrible things that can happen to people, and tinkering with it as part of our engagement with changing the expectations that people may have. But in any case, so we may come up with then a hierarchy based on severity of consequences, which again, using my guy who I illustrated before with the lab. So we have a variety of consequences. We had a variety of illnesses, some of them that were short, near-term consequences like Ebola, which if you contract it, you get sick and die pretty quickly. And then we extended it out to things that were more long-term, more chronic. And so as we worked on this, we included a range of things that were longer range ailments that would be harder to detect. Option three, so many people come in with vague consequences. They kind of say, I don't know. It just doesn't feel right. Something bad will happen. And in that circumstance, there's a different task that you really have that's beyond the hierarchy. One of them is that you're going to need to make it specific in order that you can do options 1, 2, or shortly 4. In other words, the concept that we're leveraging here, and it's one that I like to roll out that people don't hear about as much, it's called hot cognitions. So if you think about the way the therapy goes, and we as behaviorists don't operate here in the vein that I'm about to describe. So typical therapy, the way most clients expect it if they're coming for standard psychotherapy, is you come in and you talk about stuff, and the clinician engages in some problem solving with the client that may or may not lead to some actions outside of the session. Okay, so that's kind of a typical frame. However, that's an intellectual exercise where the cognitions are what we call cold. In other words, they're not relevant to what's happening in the moment. Behavioral tests make them hot. They make them accessible, they make them reasonable and relevant at the moment, which is what all of exposure entails. But when the consequences are vague, you might need to break down those items a little bit more and say, well, let's practice this and let's see what happens right now. Since it's not clear, let's see what's going to happen now, especially in the near term. So there are some behavioral tests that you may engage in, and I'll make this concrete in a moment. And then, of course, option 4 is do the standard hierarchy the way you always have around the target stimuli, and then you problem solve around the intermediary consequences. In other words, if there are longer term consequences that the person is concerned about, there probably are a series of intermediary nearer term ones that the person would see coming. And we should articulate those. This is where, if you are a fan of experimental design, very basic concept comes into play, and that's operational definition. You would work with the client. Remember, if cognitive behavioral therapy collectively is training the person to be their own scientist, then in this particular instance, you're training them to be a scientist around operationally defining the outcome that they think will happen, and the things in between. So it's construct, big term, like long-term outcome, and then elements of the construct, which is intermediary outcomes. So let's say when it comes to getting sick with a particular illness, as with my guy before standing in front of the lab, well, what are the intermediary outcomes? Yeah, sure. You're worried that at the end of all of this, you're going to have one of the concern. My apologies for those of you. I'm broadcasting from home, and my dog is barking, and so now my dog will be low key famous for everybody that watches this recording later. Um, so, in the event, let's say my guy who I illustrated before, one of the concerns he had was with contracting hepatitis. Now, before you actually are diagnosed with hepatitis, there's a whole bunch of intermediary events that would be signals that, in fact, you have this disease. That's what we would be watching for, right? It's not just exposed to this, and then 6 months later, you go to the doctor and it's like, oh, surprise, you have hepatitis. No, there's a whole bunch of things that happen before that. You have a fever, you may have inflammation in other areas. There's going to be signs and symptoms that you may observe. Our job as clinicians is to highlight those and highlight them in a way that is intended to break those expectations around the avoided stimuli. Okay. So let me tie it all together. I'm going to use my case illustration, and we'll have some summary discussion after this that will permit for some Q&A. So my illustrative case, this is a composite actually. So it's a female client, cisgender, white, 32. She presented with health anxiety, and she had two main health concerns that she reported. One was of contracting cancer. Cancer in the most vague way, by the way. It was any kind of cancer. And then concerns with having a brain aneurysm. And so those were her two health symptoms. Let me I pause a little sidebar for you guys. If you work with people who have health anxiety, for us as clinicians, you have to traffic in stuff online that is not necessarily wonderful for our own health. I recommend this with advisement. If you're going to do this, it does invite a lot of gallows humor for us as clinicians, and also it's very challenging because you end up reading stuff online that's just terrifying, and it's basically like every vague symptom can lead to something, but you have to kind of do some research yourself in order to really treat some of these kind of health anxious individuals. And that was the case with my composite client here. A lot of the symptoms are primarily from one person, but to protect identity, I did commingle that with some other things here. Anyway, so her health anxiety was around cancer and developing a brain aneurysm. She had a lot of checking related to her health anxiety, checking things like her body and checking for health information. She had superstitions related to the number 6 and multiples of 6. And she had religious obsessions about blasphemy. Her duration of symptoms was about 15 years before she came to see me. So like late teen years, which is not unusual for many people with anxiety problems. And she had some associated complicating problems. So it's not the target of our discussion today, but these two things did come into play in the course of treatment. One was that she had alcohol abuse, and the other was that she had very severe family conflict. Okay, so that's a little overview. So remember, I highlighted 4 different frames for how we might go about targeting this. So one of them, a hierarchy based on the time to consequences. So she engaged in checking due to health anxiety, and she would check for tumors. So she would sometimes check her ribs. Now, I don't know if you've ever run your fingers along your ribs, but you'll feel those muscles there. And there are spots along your ribs that may feel like bumps. This is true for all of us. Now, these things created challenges for her because she would then wonder, am I developing a tumor? And so one of the things we would do is if she checked, what she believed was that checking delayed the seriousness of outcome. So delaying checking would have consequences for her potential development of actual cancer. So you can imagine she was checking a lot. Other than when she was actually asleep, she was checking quite frequently every day. This is someone who, by the way, when she came into my office for the first time, was checking her kneecaps to see whether or not she had cancer of the kneecaps, which is an extremely rare form of cancer, but it was influenced by a famous person who had recently been diagnosed with synovial disc cancer. So we created the hierarchy based on a delay of checking related to the increased risk that it would pose for her in possibly detecting cancer. And as you delay determining this, it would increase the odds that it would metastasize. So that was the main feature of her hierarchy. We did have a hierarchy related to the severity of consequences. So her religious obsessions had to do with the degree to which a blaspheme was considered unacceptable in the eyes of her religious deity. And so some of these, as you could see, and as you look at this slide, some of them are pretty minor. Saying heck was one. So when she spoke, by the way, she was very proper, as you might imagine, and very over-controlled in her language, even though she very much wanted to say a lot of things that would be a little bit more loose and potentially included vulgarities. She said she frequently thought in this form, but it created problems for her even thinking it because she equated thinking with the moral equivalent of it being an action. I didn't list it in my list of cognitions earlier, but we do know in the world of OCD that goes by a special name of thought-action fusion. Just to remind everybody, thought-action fusion has a couple of varieties. There's the likelihood form, which is if you think it, it's the equivalent. You increase the odds of something happening, rather. So thinking leads to increased risk, or thinking is the moral equivalent of doing. And so for her, the moral equivalency is what came into play here. And so we included some things, we built up to some things, and part of it was also who did she direct the blaspheme towards? So, for example, saying the word hell in frustration and not directed at anybody, that was not great. Saying an expletive towards me, not great. I was happy to see that I was elevated a little bit above just saying it in frustration. So saying expletives towards me was something that she struggled with. We did get there, by the way. She said some pretty shocking things eventually. We then also had where part of this, because for her religious tradition would say to honor thy parents, saying an expletive towards her parents was quite problematic. And then we got to some that were really quite blasphemous, which included praying for catastrophe to befall me or her parents, and then ultimately to the concept of saying expletives regarding her personal deity. So that was the hierarchy that we constructed. And by the way, we did climb this hierarchy with some success, and I'll talk a little bit about how that was successfully navigated. So the behavioral test for vague outcomes. So the target symptom, she said, was the number 6 and its multiples. So a behavioral test that we started with was an easy one. Walk 6 steps and then stop, right? Because anytime you walk, you're going to go more than 6 steps. And she actually would keep track of the 6 steps and multiples. But then we would also do some things that were a little bit bigger, sipping water, eating M&Ms, ultimately going up to doing other tasks, ones especially that were rare tasks in multiples of 6. The goal was to get from her hot cognitions, the thought that was attached to doing that in multiples of 6. Now, by the way, what was the multiple sixes of 6s about? It was magically connected to health-related concerns. She had created a magical association between the number 6 and the risk of developing an aneurysm. As an aside, the aneurysm risk for her, I saw her a number of years ago, and it was around the time that a news figure in the New York area had died of an aneurysm. And it was a very public thing. It was a very well-known thing. There's a foundation now named in the honor of that news figure, named Lisa Colagrassi. So if you're familiar with what happened to this particular news figure in the New York area, you are aware that this happened, and it was quite an upsetting event for people that followed her work. And so this particular client, that was something that was salient for her. But the number 6 had nothing to do with aneurysms, of course. And so what we did was, when we did this, and once we elicited this, we started talking about headache risk. Why headache risk? Well, remember what I said to you before. If you're going to traffic in health anxiety, you got to know a lot of stuff about health that is scary. And one of the things that's known with aneurysms, there's usually a little bit of a warning. Not a big one, but it's enough that sometimes can save people's lives. It's called the worst headache of my life. And if you report the worst headache of my life, you should go check that out right away, because that sometimes is a harbinger of an aneurysm. And so we started talking to her about this client about headaches, as we were engaged in this activity, once I knew what it was. So in other words, when you get that hot cognition, you'll exploit it to full extent in the service of alleviating anxiety. And then we also had a standard hierarchy for problem-solving intermediaries related to her blasphemes. So we did both. So let me back up for a second. So if you look back here, with the hierarchy based on the severity of consequences for blasphemes, right? You get up to the last one, saying expletives about a deity. Well, the consequence for that would be predicted to be hell and damnation. We then also talked about how, if you climb that hierarchy, what will be some intermediary signs? So for her, the discussion was that the deity would probably give her some heads up that, hey, you know what? I don't dig what you're saying. I don't dig what you're doing, and that she would get some indicators. So we started to use that as a basis for understanding that there probably would be some consequences prior to mortality. Now, I want to add a cautionary note here on this. So this one comes up often enough that it's worth paying attention to an additional element to this. So a hazard that we started to face with this client in particular, and I've had this with others, as we talk about intermediaries, some clients go a Faustian route. The Faustian route is, well, if I discard and shed religious concern, I will be free from anxiety in such a way that I will have greater success and happiness in my life. But that will be a consequence of a bargain that I made that permits me to violate religious tenets. Now, of course, that's a problem for us as clinicians, because the goal at the end of treatment is for the person to feel less anxious and to have a more happy, fulfilling life. So we had to get away from that. We had to include that, no, doing this, your deity will express displeasure right away, like Old Testament style displeasure, not more forgiving and compassionate kinds of outcomes that would be false indicators that the client can construct a different narrative around. So we had to tinker with language. So I ask you to be attentive to that as you think about how to go about doing this. Okay, so additional critical components. So first of all, what we've been dancing around a little bit is that part of this includes directly targeting cognitive variables. And part of this ultimately requires that you develop some metaphor to drive the change. So the client needs to have some metaphor that they use. Remember, I highlighted at the beginning that that space between the exposure and the anticipated consequences, the time lag, is filled with language. And so we need to fill that language with an alternate narrative. And metaphors are a great way to do that. And metaphors, I mean metaphors and as well as similes. And metaphors that are more effective for driving action are ones that are unique and personally salient. So let's say in the case of my illustrative case of Kate, so we had to deal with intolerance of uncertainty. First of all, for all of us that walk this land, if we are religiously oriented at all, we really don't know what's going to happen at the end of our story. And so we live with that uncertainty, and that's something that we grow accustomed to. She had to kind of think about that and think about the uncertainty around a lot of other things like medical risk. Uh, Over a long enough time period, we really don't know how things will unfold. And so we have to kind of come to an understanding of that and then determine what will be acceptable risks rather than under no circumstances shall I take this risk. Part of this also then means we have to come up with a better understanding of what the overestimation of threat might be. In other words, come up with a more realistic estimation of threat. So, is walking in multiples of 6 a hazard so great that you're likely to have an aneurysm? Is it a risk so great that you would have a mild stroke? Is there a risk so great that you would have even a minor loss of cognitive functioning because not even outright stroke, but a small capillary burst? So we have to think in these granular ways around that. There's the other target, which is an interesting one that I'm including here, and that is the too few steps between exposure and the feared outcome. So if we think about the typical anxious individual will say, if I do this, yeah, let's say for Kate, if I, have 6 French fries, then I will have an aneurysm. Now, that's a big leap from that one event to an aneurysm. And so we'd have to really assume there must be a whole lot of intermediary steps that come between the action and the feared outcome. And this is true for standard worry, by the way. It doesn't have to be something like the topic at hand here today. There are not sufficient steps between the exposure or the event and the feared outcome. And so our job can be to fill in a whole bunch of other things that would have to happen between, for her, the act of eating 6 French fries and the outcome of having an aneurysm. There have to be other things in there. And so we could start spelling that out and expanding it, which makes it difficult for the person then to harbor the fear of 6 French fries because it's changed based on all the other things that have to come following that in order for it to be the thing that increases the risk of an aneurysm. And then ultimately for us here as our example, we have to come up with some kind of statement. We need something pithy that the client can rely on that will drive their action each day, given that after the session and after you do exposure with the client, it will not lead to anxiety reduction in and of itself. It's going to require that they practice this, knowing that relief is not immediately at hand. Now, for Kate, the critical self statement that we had was, doesn't really matter what happens, you have to just live your life, right? She had come to a point where she was tired of living in this level of fear. And so she used that as her statement, even though with every day, we also said we were actually kind of fatalistic. Today, you might die of an aneurysm. You still have to plan to live tomorrow. And that served as an inspiration. Actually, we had, just as an aside, and I know I'm talking about a composite case, but I'm using an incident where this client was away, had done something while away, actually had gone to a zoo and saw 6 monkeys. And so that was an unusual and very unique event. And in the act of seeing 6 monkeys, felt that she was at this unbelievable risk for an aneurysm. And we talked about how even though you may drop dead before you get to the airport, you still have to plan to live your life by getting to enjoy the city that you're in. It was a really kind of a critical moment where the cognition was so hot, so live, and the reaction was so palpable that moving on from it was like this therapeutically critical event. So these are some things to consider. I want to talk about a general rule as we come to conclusion today, and I leave some time for us to ask some questions and go through some things. So this kind of case or set of case illustrations where there's a long lag between exposure to the stimuli and the feared consequences, it follows a little bit of a script. And that is, most treatment, if we think about the trajectory, early on in treatment is generally heavily behavioral. And it's only as you get to know the person more and you've gotten a chance to do more stuff that those cognitions get live and hot that you can move to doing more cognitive kinds of interventions. So I felt that this was a timely occasion, more so than in the other trainings that we've done this year, that this point should be made. It just felt more relevant now, especially given that in the discussion today, so much attention has been paid to these intervening cognitive variables, but recognize that you really don't get to those early on. You need a few sessions under your belt with the client before you actually can start thinking about some of those cognitive variables in a more frontal and direct way. Okay, so a little summary. So assessing the lag between exposure to the feared stimuli and the predicted outcome, to me, and I think it's an underappreciated element, is an essential ingredient in treatment. I think my ad hoc experience has been that many clinicians overlook this, and doing so just creates problems when it comes to doing exposure. And so I hope that that's a big point that I've impressed on all of you today. Strategies for addressing these include some of these that I listed today, like treating time and consequence severity as components of the stimulus complex, integrating exposure with cognitive variables, and to develop some kind of guiding metaphor that is designed to drive the person's actions. And again, metaphor in the broadest terms, which includes then similes, right? If you're listening to this and you're going, well, I say this is like that, that's not really a metaphor. I know. But the point is that we think about this in the more broad terms possible. So one last thing, and my dog is insisting on intruding on our presentation today, so I apologize if you're getting that. So you'll see here we're at our 4th training in my training tour. I have 3 more coming up. I promise to be at a quieter location on the next 3. The next one is April 17th in 2 weeks when we'll talk about disgust. I'll have images to include. May 3rd, panic subtypes and exposure. And then on May 17th, developing imagery and exposure therapy. So I want to thank you all for being here today. And I'm going to open the floor for some questions. Just go ahead and type questions in the chat if you have any. I'm eager to hear any that you may have. Some of you are hesitant because it's being recorded, and you're like, wait, I can't have my question recorded for all posterity. The consequence I will feel someday, I can't have that. Thank you, Jessica. I appreciate it. I'll give everybody another minute or two in case you're formulating some thoughts that you have about this. If you saw my chat comment, I was joking. I did have, actually, this presentation, I had everything pretty well prepared before we logged on. The other couple of presentations, I was actually tweaking slides right to the last minute, but this one I had it all pretty well put together in advance. I guess I'm getting better at this. I'm feeling good about where I'm at in my development of presentation skills at long last. It's taken a while, but I got here. I appreciate you guys signing up to give me that confidence builder. I'll stay on the line a couple of more minutes in case there are some more questions. What I'll do is I'll stop recording so nobody will feel self-conscious. I'm going to end the broadcast, but I will stay connected in case there's any other questions. So, all right. So